think you're right. Recreate the spontaneity of the phone call, and people will like that.
Brandon, I'm here in beautiful Austin, Texas. Kind of surprised I made it to this meeting because of the weather that the United States have been having over the last week or so through the Midwest. Sad that you weren't able to make it here because we could have maybe recorded one of these in person for the first time. But the Prism conference right now has been really fun and it's been very interesting. And I figured, what's a better time than now for us to sit and talk? Maybe give ourselves an update on certain things. And I wanted to share with you something I came across that involves the patient population we take care of, young athletes, middle schoolers, early high school athletes. And it's probably something that you're a little bit more of an expert at than I am. So I wanted to get more of your thoughts on what we see in this video. It's pretty short, so I'm going to share it with you right now and we'll take a look. So tell me what you think when you see somebody doing something like this for a middle school baseball player. So I guess the idea is this patient has some pain when he swings dry, meaning he's not having a live at bat. He's just swinging the baseball bat. He has a normal MRI, but every time he tries to do a dry swing, he has pain. And this professional locates an area of tenderness in the lumbar spine, supposedly the paraspinal musculature, uses ultrasound guidance, gets into thickened fascia, and then that completely resolves the patient's pain. So, okay, fine. Take me through your thoughts on that. You know, you do more injections than I do. Your volumes are higher than mine. You may do them for more reasons than I do them, but I'm really curious what your reaction is to something like that.
Yeah, I would say, part of it is, obviously on these videos, like we don't ever know the whole background and everything. So, don't want to be too judgmental, but I would put that in the category of like a trigger point injection. I think when I'm hearing about an injection in a middle schooler, which we sometimes do, there's a lot of hoops that I need to jump through first before we break out the needle. It looked like they did an MRI that was normal in quotes. I want to have seen this particular patient be seen at PT and quote unquote, fail PT, not get better with that. Maybe there's some OMT or adjustments that have been done. So those are all the things that I want to see happen before we do an injection. I think and we don't know the injectate either here, but let's say, I'm in that situation and it's middle school kid and we think it's more a trigger point. I'm probably going to tell them like, hey, I really don't see that many 7th graders, 8th graders that need a trigger point injection. Maybe dry needling might be better here. Maybe cupping, maybe those modalities is a better option. And Arvin, it's not necessarily that like it's harmful. It's just like we're setting the stage to say, hey, I've been getting injections since I was in the 7th grade. I don't know. I mean, that's the main thing. Like we could talk more about like injections in general, but like that's the thing that I tell people in the clinic, I'm like, I don't want to be known as the injection guy. Like, oh, go see Hall. He'll give you an injection to play. So that's, I think, the risk you run. Obviously, we don't know what conversation was had before the injection, but that's the conversation that I would be having to be like, look, if we try this, this is the reason, this is why you're a good candidate, and this is going to be a one-time thing. I don't know. That's my thoughts, but what do you think to that?
I think you're thinking about it the same way that I would think about it. It sounds like you're saying we want to use injections in a very narrow therapeutic window in the young athlete population. I've done several injections in my career if we count residency fellowship and my years out in individual practice. I haven't injected a patient that young. Like I haven't injected like a middle schooler for a somewhat non-specific indication, back pain. So my thoughts are that if you have a diagnosis of low back pain, you get imaging studies and there's no concerning MRI findings, and the patient went to PT, tried cupping, and then still has pain with sports. I still struggle philosophically with that because I know that this is a very contrived mechanical issue. Like something's not engaging properly in the posterior chain. There's something off balance. One side of paraspinal muscles are working too hard and the other side are not activated enough. There's some imbalance there that's contributing to this. And fixing that imbalance will make the pain go away. And putting a needle and injecting a trigger point or thickened fascia shouldn't be seen as a replacement of fixing your mechanics. Because, like you, yeah, I also don't want to be the person that's known as the person who'll just put a needle in whatever. But I also don't think it makes sense if we think about the medium and long term health of that athlete, because the whenever an athlete in that age group comes to you for a problem like this, it's important as a sports medicine physician to understand that the body is trying to tell us something. It's trying to tell us a story of why it's causing the patient pain. And we're just kind of like putting duct tape over its mouth when you inject it and make the pain temporarily go away. We're not listening to the story and fleshing out the diagnosis appropriately, thinking about the contributing factors, and then using that information to come up with an informed treatment plan of rehab and biomechanical training to make the pain eventually go away. So I'm with you on that. I think it doesn't philosophically make sense. And I tell parents, and I'm curious what you think about this. I tell patients and parents, if you're a carpenter or a plumber or an electrician, you're 40, 50 years old, and your lifeline is your job. Like, you need to make money so you can pay the bills
Mm,
and take care of your family. And you've got chronic wrist tendonitis, chronic elbow pain. It's making it really hard for you to work. And you don't have the time or the resources to take off a month and a half and go to PT and try all this other stuff, which will work. You don't have time for doing all that. You need more of a quick solution so you can keep working. Even in that situation, we shouldn't think about injections as the treatment, but it's a little bit more justifiable because there's other things that are contributing to that person's life. And they're a little bit more understanding of what the pros and cons are because they're a full fledged adult and can understand the risks and benefits of doing injections in the short term, medium term, and long term in that scenario. If you're an 11-year-old or 12-year-old and you play baseball and your pain is with swinging a baseball bat, but you're not having pain at night, you're not waking up with pain, it's not like affecting your day to day life by and large. In this scenario, you still have your life ahead of you. You've got school to go to. You've got friends you can hang out with. There's so many things outside of baseball. You don't depend on baseball to raise your family by and large. So if you're 12 and you've got pain with baseball, then you know what? Maybe we'll switch positions. We won't let you bat for a little while. Like, we'll modify things to remove the aggravating factor, but let you live your life. And I think it's silly to like do an injection in that age group just to like push them through this discomfort. What do you think about
yeah.
that?
No, I say that same exact phrase about like I'll be joking with the family and just say like, like for mom, you like if you need to get to work and do the thing you need to do to pay the bills, like yes, we can be more aggressive here. But for you, 12-year-old, like that's just not something that we're necessarily going to do. Now, I agree too. I'm adding the rest part. Like to me, that's that's incorporated in that pre-intervention phase, right? So, again, we don't know what happened in the video before, but it's like it's a different scenario when someone comes and they're like, "Hey, I've done PT, 2 rounds of PT, 6 to 8 weeks for both rounds, high quality physical therapy, whatever modalities. I have not done this swinging of the bat for 3 to 6 months, something like that, then I'm like, okay, like we can be a little bit more aggressive here. And I don't even know that I would do that at that age. If we're talking about 16, 17, 18, I may be a little bit more loose with it.
Amendable to
But
that.
yeah,
Yeah.
I think that's probably how I'd approach it. Now, the thing that I thought was just kind of interesting is that the video seemed to be like, again, I don't want to say like brag, but like the point of the video was that the pain went immediately away, which I think we both know like maybe that was more of a diagnostic injection to say, hey, this thickened fascia is the site of concern, and we can confirm that with this diagnostic injection. But that wasn't expanded upon and through the video. But like I'm okay with that. I'm okay with a diagnostic injection in certain instances to help decipher. So let's say that was just a lidocaine injection, or a ropivacaine injection. Okay, like that's actually pretty thoughtful.
Yeah.
So I
And it also might
definitely
be
done that.
reassuring to the athlete that there is a way out of this. Like, look, we can make
Yes,
this go away. So there's like a
yeah.
light at the end of the tunnel.
Or hey, like the family keeps insisting that it's a particular diagnosis, or they say, oh, his dad has this X condition and we think that this is what it is. And then, after this particular intervention, you can say, okay, well, you had 100% resolution with ultrasound guided diagnostic injection. we all can let our guard down a little bit in terms of the more dangerous or concerning diagnoses there. But I think the video doesn't do a great job,
Fleshing that out.
yeah, discerning between like, is this a curative injection or not?
And I would think that there is another avenue I think about, which is that some trigger points develop very chronically and they are a nuisance that then bother the patient, even at rest. So there are some trigger points where even when you remove yourself from sport, it still hurts to carry a backpack and sit in a certain position in school. And like you, if you've done the PT and we've done the imaging studies and there's nothing else there, children deserve not to be in pain 24/7, right? So if there's an intervention where we can get them out of pain, and they can go back like with the goal of just like getting a normal life back before we talk about sports, then that's a good, in my opinion, that would be a reasonable indication to try things like trigger point injections. Do you think you think
Yeah,
about it the same
yeah,
way?
yeah. I think actually did one recently, but it's like a 16, 17-year-old just, like living her normal life, has done the PT, has done everything I asked her to do, and is just, tender several, spots around the shoulder. I think that's very reasonable. But the next question to ask is like, what's your injectate? So in that
Hmm.
scenario, I think you could just make an argument for lidocaine or numbing agent to maybe what people would call like break the pain cycle. So like giving them a pain-free, short period of time where they're like, okay, yep, it's coming from the muscle. There's nothing torn inside my shoulder, even though the MRI was, supposedly normal. That's one option. I don't think too many people are doing like a corticosteroid for a trigger point injection, but I think some people are doing PRP. I think it might be reasonable to consider a hyperosmolar dextrose solution. I think those are all reasonable options. And obviously there's injections for lots of different areas for lots of different reasons, but I think that's what I might be considering in that scenario of the older adolescent with chronic pain that's affecting day-to-day life.
Yeah, I think that's a good launch point to the next part of this. This injection we just watched, the idea was sort of like trying to separate the thickened fascial layers, and then coincidentally, if there's a so we use the word trigger point. What we mean is a muscle spindle within a muscle group that's sort of bunched up and became very tender to touch and is making it very hard to use that muscle group without pain. And if you think about like a knotted up muscle, some of the classical teaching on this has been that it may not really matter so much what your injectate is, but the action of the needle breaking up that muscle spindle knot is kind of more important to get the patients out of pain. And so you can choose lidocaine, you can choose normal saline or extra sugary water, basically hyperosmolar dextrose. Any of these injectates might be fine, but not worrying so much about what the injectate is doing, but focusing more on if your needle is properly breaking up that tissue into getting it to relax over the long
Yeah,
term.
the mechanical disruption
Yes.
may be actually more important than in the actual injectate, and I think that's
And then it's like
important
that leads me
in
to dry
kids.
needling, which you mentioned. It's like,
Yeah.
that's the point of the dry needling is to like sort of break up the tense muscle tissue to try to get the muscle to contract in a more organized fashion rather than being bunched up and causing pain.
Yeah, I think that's very reasonable to consider. So I will say, just as like a general overview, I probably in the pediatric population, the most common injections that I am doing are like a subacromial subdeltoid bursa injection, a intraarticular hip or iliopsoas bursa injection, primarily for snapping hip or subtle labral tears. Um, and those are like the big ones. I would say what I have been doing more and more of, and we're trying to publish a paper on this, is some Hoffa's fat pad injections. I think that diagnosis is kind of lumped into the patellofemoral pain diagnosis. And actually, I think we'll see more and more on these MRIs that there's actually some irritation or edema on the Hoffa's fat pad, and it's kind of getting caught in between the patella and the femoral condyles. And we've done several, injections where we'll try to go more in depth in it, but we'll try to basically separate it off the patella tendon and try to shrink that Hoffa's fat pad down. So those are the main ones that I'm typically doing. Then, just one-offs here or there, a draining of a cyst or something like that. But those are the primary ones. And then I would say add on is the patella tendinopathy. I have found that the hyperosmolar dextrose tendon fenestration seems to give a good outcome as well. So I'd say those 4 or 5 are probably the highlights of pediatric population, in my opinion.
Yeah, let's break down some of those. So you started with subacromial bursa injections in the shoulder. So, to sort of get into more specifics about that, when we use the word bursa, what we mean is a sort of a fluid-filled sac that's found in various areas around the musculoskeletal system in the body, various joints, various muscle groups. And the idea behind these bursas is that it provides a way for different layers of skin, subcutaneous tissue, muscle, and tendon to sort of glide smoothly over each other to minimize friction so that you can get good function of movement of various joints. And one of the most common bursas that get irritated and inflamed is the one in the shoulder, and it's referred to as the subacromial bursa because it's underneath the acromial process, a bone in the shoulder. And this is a common reason that people of all age groups, including adults, get injections into their shoulders to try to calm that bursa down and give them some more pain-free function of the shoulder. In our pediatric athletes, our young athletes, the subacromial bursa would get irritated in sports that involve a lot of overhead lifting. So we would think about stuff like overhead weightlifters. We talk about gymnasts, maybe some baseball players, overhead throwers like baseball players and quarterbacks,
I'd
and
say
volleyball
volleyball,
players,
softball. Yeah, yeah, yeah.
volleyball,
Volleyball,
softball, and then
softball.
the other one, swimmers too. I know they're
Yes.
overhead, but they're not lifting anything above their head. So those are the athlete populations we typically see that diagnosis in. And I just want to bring it back to the way we started this conversation. I'm curious, like if you've got a swimmer, let's say 13, 14-year-old swimmer, chronic shoulder pain, you do your exam and you see that it hurts to do the provocative maneuvers that irritate the bursa are positive, but they otherwise have good use of the rotator cuff. You're not worried about some labral damage there. You think your diagnosis is just that bursa is inflamed. Maybe you slap an ultrasound on there, compare side to side. One bursa looks a little bit more generous than the other. That helps you confirm your diagnosis. So when we talk about the philosophy of this, do we say, okay, young athlete, pain is with sports, not really affecting them during life otherwise. Let's slow down the volume. Let's send you to physical therapy. Let's try that first. Let's see you back, see how you're doing. And if they fail that, then consider injection after the fact. And then I would argue, like, in all of these scenarios, just like you mentioned, and we'll talk about each one, like the shoulder subacromial bursa, I know that the conventional teaching is that you could do a steroid injection there and it's relatively safe and well tolerated and can give some long-term pain relief. My philosophy is similar to what you mentioned earlier, where I'd rather just inject it with a short-acting anesthetic like lidocaine or bupivacaine and then convince the athlete and the parents that that injection temporarily resolved the pain completely, which then gives them the proof that they need to make sure that they understand how to move their shoulder mechanics to make the pain go away on their own. I just buy teaching an athlete to make their discomfort go away by biomechanical retraining is a lot like teaching a man how to fish so he can feed himself. Whereas just doing the injection is just giving him fish and then letting him, he'll have to fend for himself. So take me through that. Do you think you agree with that process, or are you a little bit more loose with your indications for that injection? How do you see it?
Yeah, I would say, and I know this is what you mean when you're describing the bursa. Like, I would say the majority of these patients have subacromial impingement, right? We're not assuming that all of the patients that have impingement have bursitis.
Bursitis.
In fact, like, when you look at the ultrasound or look at the MRIs, it's pretty rare that the bursa actually has fluid in it in this population. So sometimes you're treating like symptomatic impingement with no like large bursa like you might see in an adult. But I'm right with you. Like, I'm basically like, I've got to be convinced that you've done everything and like it's doesn't even come up in conversation for several visits if the patient's not getting better. Like, I'm not usually bringing that up at all because it's mechanics, mechanics, mechanics. Like, that's what the issue is here. And I totally agree with you on the diagnostic injection. I would say I'm a little bit maybe more aggressive if I'm going to just commit to some corticosteroid in this particular situation. But I do think that we're talking injections just because it's the topic, but this is probably very, very, very little of what we do in terms of percentage of patients that we see. The majority of patients who have this impingement, whether they have bursitis or not, you're going to try to convince them that the therapy is what they need, the mechanics is what they need, the rest is what they need. You might get of the 100 patients you see with the shoulder, you might get 5 that are, like, resistant to getting better, and that's the ones that you might intervene on. So, yeah, I think that's how I would approach that as well. Sometimes too, like, these cases where you're like, "I can't tell if it's the biceps tendon, I can't tell if it's impingement," sometimes just being able to, like, tease that out a little bit is helpful. Then you can give the physical therapist some direction of, "Hey, this is what I think is going on." Sometimes it's secondary to hypermobility, which, that's a whole nother ball of wax, so I think that's reasonable. I think we both are a little limited on our exposure to all of the inner workings of PRP, and so I think that would probably, if we had a PRP expert on, they would probably say that's another option there as well. But that's my kind of process when we're dealing with the shoulder.
And I would say, just to talk to piggyback off the PRP conversation, it's so far at this conference, it's been mentioned once or twice in passing, and the same, I would say 2026 is presenting the same issues that 2025 and 24 and 23 presented, which is that there was a lot of promise for PRP being sort of a cure-all injectate for many different problems. And in the pediatric literature in particular, we are not seeing it flesh out in the data that it creates this huge solution to musculoskeletal issues in kids. So we can talk about the safety of it, which I think is probably pretty robust. It's relatively safe. It is, after all, something that the body already makes that you're using. And to get into the specifics of that, basically, when we say PRP, we're talking about platelet rich plasma. And the idea is that you draw a patient's own blood and you use a centrifuge machine to spin the blood so it separates into various layers. And that topmost layer is a sort of clear to yellow layer of what we call plasma, which contains the platelets, which are the blood cells in the body that are responsible for clotting. And the idea is that you draw that up and you inject it into the area of diseased tendon or joint. And that patient's own plasma contains the nutrients and the inflammatory cells and the signaling cascade that that specific disease tendon needs to help heal itself or to help facilitate an inflammatory process that leads to healing. That's the philosophy behind it. That's the basic science behind it. It sounds very, very graceful. It sounds very, very nice. It sounds very poetic. But when the rubber hits the road, we're not seeing data that is very convincing to all of us that these injections long term solve the problem. And I would argue, even if we had that data, you'd have to figure out a way to prove that that's better than just doing conventional rest and rehab. Because who would want to inject young children with something they wouldn't need, even if the data shows it can help, when the way we used to do it without an injection does just as good, if not a better job. So I think the
Yeah, and
literature.
and let me ask you this, because and I think we both could do the exercise of, like, there's so many variables when it comes to PRP, right? It's like anybody can say they're giving you PRP, but is that actually how much blood did they draw? How long did
Mhm.
they spin it? Did they do 1 or 2 spins? Is it activated? Is it leukocyte rich? Is it leukocyte poor? Like, there's so many variables that I think haven't been teased out. So it's not to say there won't be a time when it can do wonderful things, but I don't think we're at that time. And moreover, I think anybody who portrays it as such, especially in the pediatric population, is being a little bit disingenuous in their indications, in my opinion.
And it's also not to say that there are many anecdotal stories of kids and adults who got a PRP injection and they're like, that solved everything. Like, that fixed everything. And in no way are we saying that they are not being serious when they say that. They very likely are benefiting from an improvement and resolution of their symptoms. It's just that when you do research and you try to figure out what would be a good recommendation for everybody in the country to do, the number of patients who receive those injections and are reporting that kind of remarkable recovery is not happening frequently enough that it makes sense to give a broad-based recommendation to allow its use or regulate its use or tell people to do it more. So the signal is there. There clearly every month I might meet somebody who says that they got a PRP injection or know somebody that got a PRP injection and that they resolved their symptoms. And that's great. But in the pediatric data for the problems that we take care of, the frequency with which we are seeing children benefit from these injections is not high enough to warrant a broad-based recommendation that we should be doing it a lot for shoulder pain or hip pain or knee pain or whatever the case is.
Yeah, I think that's fair, and, obviously there's cost, and I think what's hard though is, this is a very not maybe this is a very politically correct discussion, but some people are going to come to you and say, well, is it going to hurt? No. Okay. Well, then I have the money to pay for it. So let's
That's
just do
true.
it, you know?
That's true.
And I mean, I know injections don't typically have a lot of side effects, but they're not benign. I think, I don't know, like, I think then I just circle back to, like, again, what are we doing here? Like, are we just, injecting 14-year-olds because it's not going to hurt?
Yeah.
You know,
This is
I
a
don't
good point. I think medicine in general was far too paternalistic historically, and we've done a good job. The medical community has done a good job empowering patients to be in charge of their own healthcare. And I think that's a good move. But at this point, especially in our field, the utilization of injections and getting advanced imaging studies like MRIs and CTs, I feel like we've kind of become very sensitive to the climate, and we're pretty quick to be agreeable to parents and families that we will do things that if we chose to do, like if we were going to do them for ourselves, we probably would say, like, I don't think that's necessary. So what are your thoughts when you have these conversations with patients and parents who come in sort of with the expectation that Dr. Hall is going to offer me an injection, and I'm going to ask Dr. Hall for an injection for this problem? And then you think about your own training, you think about how you think about problems and process issues and think about biomechanics, and it's clear to you that there may be no harm in this injection, but it's not sending the right message, and it's not really in the best interest of the patient long term. How do you grapple with that?
Yeah, I would say that the number one thing I say in those conversations is just like, "Hey, I'm not saying it's wrong. I'm not saying it's harmful. I'm just letting you know what I'm comfortable with, and I'm not comfortable with doing that." I've had many patients do very well without it, and I'll tell them like, "Hey, like my recommendation is for you to get a second opinion. Here are some docs that I think might be more open to doing that." And I think when people hear you say that, I think it opens their eyes, right? Like, I know this is kind of a snarky way to put it, but I tell people like, we get paid much more for doing things like injections than sitting and talking with you. And so if I choose to sit and talk with you and explain it in a way that is detailed so you understand biomechanically what's happening, rather than something that takes much less time and pays much more money, that should be something that let that sink in a little bit, and so it's not that I don't want to do it because I'm lazy. It's because I don't think that's what's in your best interest. And it's this,
That's a very key point.
it's the oath, right? Like, what's in my best interest financially is not what's in the best interest of the patient. What's in my best interest time wise, efficiency wise, is not what's within best interest of the patient. But I would never choose my time or money over the patient's best interest. And I think, maybe it's not said exactly like that, but that's basically what I'm trying to explain to a
I
family.
think I think the way you just said it is how people should understand. When you see a physician who is going to be incentivized to do more, the surgeons want to operate, the sports medicine doctors will benefit from doing lots of injections. I mean, how many of our adult colleagues who work in colleges and universities and that older population group have like injection day where they've
Hmm.
just got 30 patients scheduled who are all going to get an injection for one reason or another, and they have all of their medicines already pulled, and they've got all their needles and their syringes and everything ready to go, and they're just going to go into one room after the other. If you run a practice like that, it can be very lucrative. Those colleagues are probably making two, three times what we make. Whereas even though we are spending far more time working dynamically with patients and families to get to the real diagnosis that we want to treat. And our populations are different, right? Like we don't have 50, 60, 70 year olds coming in with arthritis that's not getting better with PT. Like that's a good indication to inject people later on in life to get them through their arthritic pain. So we're not taking care of little kids that have degenerative disease of the joint. So but to say that even though the healthcare system is not necessarily different in kids in terms of where the incentives lie, if you could finagle a way to make an injection clinic, it is more financially rewarding for you to do that. But we and most, I would say all of our colleagues just don't like the idea of running an injection clinic in a patient population that, if we just use our common sense, would get better for most of them, with some rare cases, of course, but for most
Yeah.
of them.
Yeah. No, I always have to laugh because I'm like, I think a lot of this comes back to the environment that we have in sports, right? The NIL environment, the self branding, I can make real money as a influencer, as a high school star, as a college star, right? And so sometimes all of this little, feel good that we're talking, that nobody's trying to hear that when,
Yeah, that goes over people's
there's
heads.
but when there's 10,000, $100,000 on the line, if my child is playing or not, they're not really that interested in hearing like, let's rest and let's modify and you should get better. I think we're seeing patients that want results more quickly because the ends kind of justifies the means, basically.
And I would say I feel very comfortable in these conversations telling parents, like, if this was my family member, if you were my family, I'm not treating you any differently than I would treat a member of my family. Like, if I was in your shoes, I wouldn't be going to look for a physician who would inject my
Mhm,
child. That's
mhm,
not what I would be doing for myself. And so usually that reassures most parents that, and then I do the same thing as you. Like, I offer a second opinion with one of either my colleagues within the same system I'm at, or of a competing system. I'm fine with that too. And I always welcome people who get, because you trained me to be this way. I welcome people to get second opinions, third opinions, whatever they want, because I feel conviction in the way that I think about things, that I'm convinced that the right answer is the one that I've worked hard to figure out, and that the other reasonable, similarly trained people that I work around will also reach the same conclusion because it's the right thing for the patient. And so that is kind of the foundation of how I think about injection therapies on the whole, in the patient population that we take care of.
To round out the rest of the body, I think I would say I much more similarly do the diagnostic injections like you talked about in the hip. So, for example, an MRI that shows some fraying of the labrum. Is this labral? Is this iliopsoas bursa and a dancer? We'll do an intra-articular injection, give the patient 10 minutes, 15 minutes, see how their symptoms resolve, have them do the snapping, the Faber testing, then consider, so that's definitely a good option. I want to go back to the Hoffa's fat pad because of most of the injections, that's the one where I feel like we've been seeing consistent improvement where a patient is presenting with chronic knee pain, has done all the, failed everything that we talked about in the beginning of this discussion. MRI is done. There shows some edema within that Hoffa's fat pad. This is a case where I will do a very simple corticosteroid injection to try to shrink that fat pad down, maybe a little bit of hydrodissection of the fat pad from the patella tendon. Again, you're using lidocaine so you can see if you're getting a diagnostic benefit as well. But we're trying to publish that, just a case series of those. I think,
Yeah.
this isn't groundbreaking. It's just that I think sometimes we get in this, not really that big of a deal, patellofemoral pain. They just need to do PT, next patient type of mindset. And I think
Yeah.
this is a little nuance.
I like that. To clarify those terms a little bit more, we knee pain in middle schoolers and high schoolers is one of the most common complaints that comes to see a pediatric sports and orthopedic practice. And in my practice, I would say that that age group that comes to see me with activity related knee pain that has not had an injury, right? So if there was an acute trauma that changes things a little bit, that can still sometimes be like sort of acute fat pad impingement, but you're talking more about like late, like slow onset knee pain over time. That's one of the most common reasons people come to see me. And of the diagnoses I make, I would say that Hoffa's fat pad impingement is the most common diagnosis I give in that scenario. And basically, what's happening is that there is a mass of fat cells that sits underneath the kneecap, but in front of the knee joint, just behind the patellar tendon, the main tendon of the knee. And this tissue, through growth and development and activities, can find its way getting pinched in the way that the knee mechanically moves. And a little bit of pinching is usually not a big deal, just leads to some knee soreness that goes away. But chronic pinching due to repetitive activity over time can lead to really bad, very uncomfortable pain that comes on randomly. And it can hurt patients when they change positions from sitting and standing. It can hurt them when they go on long walks. Like, it can be a very nuisance and annoying knee pain. And so it's interesting to me what you're talking about, because that's probably one of the most I probably give that diagnosis in the order of tens of patients per week who come to see me with knee pain. That's usually the diagnosis we're going to get to. So like you said, classically we think about that as the mechanics of the way the knee is moving is not optimal for your age and development. We think primarily the issues are that the hip muscles are not engaging properly on your symptomatic side. We need to make those hip muscles work better, work more congruently with the rest of the leg. Once those hip muscles line up the leg better when they're walking and running and jumping, then the knee pain will go away because the fat pad will stop getting pinched. And I think, I would say that my success rate for patients who follow through with the rehab is pretty good for that problem. The other thing is like fat pad impingement isn't degenerative, right? So it
Mhm.
doesn't turn into arthritis later on. It's not joint disease. It's impingement of a fatty tissue that's outside of the joint. So it's not dangerous in the sense that the pain will lead to a bigger problem. But it can be dangerous to an athlete because if it compromises your knee mechanics because it hurts so bad, then you might tear your ACL or your meniscus or something because you don't trust the knee or you're favoring the other side more and you're not moving in a biomechanically sound way. So it's not a problem I like to ignore, but it's also a problem I like to reassure families that like, don't worry about this being a cause of knee pain in your 40s and 50s. Like that generally shouldn't happen. So on that note, you talked about corticosteroids. So steroid injections designed to reduce inflammation in different areas of the body. One of the side effects of steroids in terms of their injection into various parts of the body is that they can atrophy or make smaller fatty tissue. So you can get fat atrophy in areas that have very thin fatty tissue already. Like if you do a lot of injections into the hand or into the bottom of the foot, the sole of the foot, you can get some atrophy there that can lead to some cosmetic appearance that patients don't like and discomfort later on. But funny enough, like makes a lot of sense. Like if you have fat pad impingement and the tissue is fatty and getting in the way, you do a little corticosteroid that has the side effect of shrinking the fat. Well, that's great. And you've solved the problem a little bit because like it's smaller now. It's not getting stuck into the joint. So it makes a lot of sense what you're saying and how you're thinking about it. And I would say that like for arthroscopic knee surgery, a lot of our surgical colleagues will puncture the fat pad purposely, or, that's really the only route to get a scope into the knee. And many times they remove that fat pad tissue or parts of that fat pad tissue and they do various things to that fat pad tissue because their interest is in making sure that the meniscus is repaired or the ACL is reconstructed. And the fat tissue, the infrapatellar fat pad is kind of a second, sort of like a bystander. So there's not, and a lot of those patients do quite well postoperatively. So it's not a super important tissue in terms of you have to be very respectful to it. You have to be respectful for the stuff around it, but you may not necessarily have to respect it quite so much. So I think that does give a lot of leeway to maybe consider changing the way that we've thought about that problem. I still think foundationally, like fixing the mechanics is the best way to solve the problem because if you shrink the fat pad, you do an injection, like I still think they can get it later, right? You might be able to solve it for 3 months, 6 months, a year. But if they switch sports or they take a break and then go back to sports, their mechanics are compromised, like it would just come back. And so I believe in the idea of biomechanical education so that if they see me at 15, they fix the problem, they take a break from sports and they start playing recreational sports at 25, they don't see me anymore, they moved across the country. If they have the same knee pain, they could just remember what I told them and they could fix it again. So I think the longevity of that advice is still really sound. And I'm kind of curious what you think about the balance between that and maybe an avenue where injections make more sense than they might have previously made sense.
Well, I think, and maybe we didn't establish in the conversation before, right? I would say it's safe to say we're never really saying that the injection is the solution. We're saying that the injection is a temporizing measure to allow you to correct the biomechanics that we thought needed to be corrected from the beginning, right? So that I think is spot on to say, yeah, like there are people that just can't do the PT. The therapist will tell you, like, hey, like we really can't do much because they're in too much pain. That's a good option there, and I think that's probably my main takeaway from that portion is just to say there, and this is what I'm doing, my consent for the injections and stuff. Like this 100% is not a cure for your condition. um, I think we've talked about this maybe on a different one where I'm like, the therapist is the mechanic. I am literally just jump starting your car, jump starting the battery so that you can actually like drive to the mechanic and do the test that they need to do because the power's back on. Like that's the mindset that I have. But that's hard to convince people because, they watch ESPN, they watch the news, and it's like such and such person got an injection and they're cleared to play on Sunday. And for that matter, I'm not even offering an injection if someone's in season anyway, so there's a lot of different factors there, but the main one is the injection is not the solution. It is a temporizing measure to improve your movement biomechanics.
And I think that that's probably like foundationally, that is true for every injection into the musculoskeletal system, in my opinion. Like, even if you've got a 65-year-old, 70-year-old who's got bad knee arthritis, yeah, they'll do steroid injections up to 3 or 4 times a year for that joint. But the literature is clear that, first of all, repetitive corticosteroid injections into the same joint likely accelerate the cartilage degradation. So your arthritis on imaging is getting worse, where you're losing the cartilage that you have started to lose, which is the diagnosis of arthritis, is accelerating with more injections, even though the injections give you a lot of pain relief. So the injections even in arthritis management, which is where they've been most classically used for the longest amount of time, shouldn't be used with the intention that that's any solution to your pain. However, really bad arthritis makes it hard to do the rehab. And physical therapy is the only reliable method of intervention. And physical therapy, like modalities like Tai
Yeah,
Chi and a
yeah.
few other things, movement training, basically, is the only scientifically backed intervention that significantly, at least statistically significantly, so that it does it frequently enough that it's worth recommending. It decreases the chances of a person going from the diagnosis of knee arthritis to requiring a total knee replacement. So that isn't to say that it prevents 80% of people from getting a knee replacement, because the effect isn't that much. So when I use the word significant, I don't mean that it like saves more than half the people that get arthritis from needing a knee replacement later, but it moves the needle a little bit, but in a measurable way that's effective enough that everybody should be doing it. Because over enough millions of people that have arthritis, if all of them do it, tons and tons and tons of them will end up not needing a knee replacement, which will save themselves all the issues related to undergoing a big surgery and the post-op recovery, decreased rates of infection, all that sort of stuff. And our orthopedic surgery colleagues are already overwhelmed with the number of replacements they have to do throughout the country. So the healthcare system would benefit, patient health dynamics would benefit. And so just to piggyback off of your very good point that the injection is a temporizing measure to get you to do the PT that would give you the most amount of benefit, whether you're an athlete or whether you're later on in life not in athletics anymore and have degenerative joint disease. That's the same philosophy. The injection shouldn't be seen as the fix for this problem. It should be seen as a way to get you comfortable enough so you can do the fix yourself.
Yeah. I mean, I think we've covered quite a bit, and I think there's always nuance. There's always nuance. That's what's so hard. It's like there's nuance. There's family dynamics. There's MRI findings that may be conflicting to what you see from a clinical perspective. I just think what I would want people to know is like it is not as simple as like cookie cutter algorithm, right? There's a lot of thought that goes into, should I do this? Shouldn't I? If I do it, how much rest? Where do I inject? What is my inject date? What's the athlete's sport? Are they in season? Like there's so much to it. And I think, that initial video bringing it back, just doesn't do that thought process justice. You know what I mean?
And maybe it's there. And like you said, like maybe they just didn't flesh out that, hey, this kid's in PT. He's with a swing coach, and this is just a way of us showing how we can make sure that we're on the right track.
Yeah. Yeah.
And if that's the case, then I'm all on board for that. But if the idea is that we're going to promote haphazard injections into soft tissue of various athletes at different ages of life with getting them patched up and sending them back out on the field, I think that's missing the mark in terms of the essence and spirit of how to keep kids safe while playing sports.
I think that's well said and a good way to end it.